So in this presentation, we will be presenting a case of mitral clip in which we had significant challenge with the quality of three-dimensional imaging as well as localization of the jet on the line of coaptation. We had to resort to traditional two-dimensional imaging with numerous probe positions and scan plane rotations to complement and supplement the information that we received with three-dimensional imaging for the optimal deployment of mitral clip. So let's get straight to our case presentation, which demonstrates that it is a 68-year-old male with severe mitral regurgitation who was referred for a mitral clip procedure. And in this focused view of the mitral valve at 0 degrees, it is obvious that there is significant retraction of both anterior and posterior leaflets, with posterior leaflet retracted more than the anterior leaflet, and consequently there's an anteriorly directed jet. When you look at the mid-esophageal long axis window, the same picture can be very easily appreciated as both leaflets being retracted, with the posterior leaflet being retracted more than the anterior leaflet, an anteriorly directed jet, and you can see a retracting cord of the anterior leaflet, giving it a typical hockey stick deformity that is so characteristic of ischemic cardiomyopathy. Next, we looked at the transcommissural view, which demonstrates the P3, A2, P1 scallops of the mitral valve, along with the posteromedial and the anterolateral commissure, which demonstrated both commissures having significant mitral regurgitation, which is evidenced by two areas of flow convergence, which means the jet extended from the anterolateral commissure to the posteromedial commissure. Next, we obtained a live wide-angle en-face view of the mitral valve from the left atrial perspective. It was not of the greatest quality, but we were at least able to appreciate that there is bilateral leaflet restriction. There was significant dropout in the posterior part of the annulus, and we could see a broad jet originating from the line of coaptation and demonstrating coanda effect in being posteriorly directed. So the situation is that we have a patient with severe eccentrically directed MR jet with bilateral leaflet restriction posterior more than the anterior. The jet seems to extend from the anterolateral commissure to the posteromedial commissure. Three-dimensional echocardiography is of some help, but doesn't answer all the questions. We know there's a coaptation defect at A2P2, and one clip needs to be deployed at the A2P2 location. But it is uncertain from the information that we have so far if we have to deploy another clip, should it be on the lateral or the medial side of A2P2. So that's the dilemma that we are facing right now, which we cannot resolve with a three-dimensional imaging. Two-dimensional monoplane examination of the mitral valve is one of the less appreciated systems of examination. This method of examination is based on the anatomical orientation of the mitral valve, in that the lateral portion, that is the A1, P1, and the anterolateral commissure, is more anteriorly and superiorly located than the posteromedial commissure, which is obviously more posterior and more medial. Therefore, when the probe is placed in the upper esophagus at 0 degrees, the first scallops of the mitral valve that are seen are A1, P1. With progressive advancement, the probe and the scan plane moves through the A2, P2, and eventually with further advancement, the scan plane intersects the A3, P3 scallops of the mitral valve. The system can be used to identify the structural abnormalities and location of the regurgitation jets when a three-dimensional echocardiographic examination is suboptimal or higher frame rate images cannot be obtained. Therefore, in this case, because of the ambiguity of information that we obtained from three-dimensional imaging regarding the lateral or the medial extent of the regurgitation jet, we decided to employ the monoplane examination of mitral valve, in this case, with simultaneous color flow Doppler examination to identify the location of the flow convergence and the regurgitation jets, either medial or lateral to the A2P2 scallops of the mitral valve. So as step one, we position the probe in the upper esophagus at the lateral and the most superior portion of the mitral valve, and that's A1 and P1 scallops. As you can see in this specific recording, that there is some regurgitation jet, but there is no flow convergence, which means the origin of the regurgitation jet is not at A1, P1 scallops. When the probe gets moved towards the middle portion of the mitral valve, that's the A2 and P2 scallops, you can see that you can visualize the regurgitation jet much more easily, and at the same time you are visualizing the flow convergence, which implies that A2P2 is the site of the origin of the regurgitation jet. Now, in this clip, the probe has been advanced to the A3P3 location, that's the posteromedial scallops of the mitral valve. As you can see that the area of flow convergence has increased in size significantly, and as has the size of the regurgitation jet. That implies that this A3P3 location is the site of the dominant regurgitation and the effective regurgitant orifice area. Based on this monoplane 2D examination of the mitral valve, it can safely be assumed that the site of regurgitation in this specific patient is A2P2 and A3P3 scallops of the mitral valve, with a major MR jet originating from retraction of the A3P3 scallops of the mitral valve. Whereas three-dimensional echocardiography was helpful, but the monoplane two-dimensional examination of the mitral valve with color flow Doppler was actually more helpful in specifically localizing the site of the origination of the MR jet. And therefore, we plan to place the first mitral clip at A3P3 or slightly to the medial side of A2P2, and then reassess the situation to see for the severity of regurgitation after the first clip to decide whether or not a second clip should be applied.